Welcome to the deep dive. Today, we're really getting into the details of a specific medical procedure based on a set of sources we've gathered. We're focusing on carotid endarterectomy. Our goal here is to unpack what these sources actually tell us. Think of it as us doing the reading for you, pulling out the key insights, maybe some surprising bits, especially if you're trying to understand this procedure, perhaps for yourself or maybe for a loved one. We're talking about surgery on those really important arteries in your neck, the carotids that supply blood to the brain. So let's start broad. What's the main takeaway from these sources about why this procedure is done?
Well, looking across the materials, it's clear that carotid endarterectomy, or CEA as some sources abbreviate it, is primarily considered for patients who have a significant narrowing that's the stenosis part in their carotid artery. And it's especially considered if they've already had symptoms like a mini stroke, what's called a TIA, or even a
Okay.
full stroke. The main goal, really, according to these texts, is to substantially lower the risk of that person having another, potentially more serious stroke in the future. The sources also often put it side by side with other options, like carotid stenting.
Right, so it's about prevention, basically, clearing out that blockage to protect the brain, particularly if there's already been a warning sign. Makes sense. But obviously, before any surgery happens, doctors need to know exactly what they're dealing with. How bad is the narrowing? What does it look like? How do the sources say they see inside the artery?
Yeah, that's a big focus in the sources. They detail several imaging techniques, essentially different ways doctors can get a picture, and often more than just a picture, of what's going on in that carotid artery.
What's the starting point? Usually something non-invasive, right?
Absolutely. The sources really highlight duplex ultrasound.
Mm.
This comes up again and again as a key initial tool.
Okay, ultrasound, like the kind used in pregnancy, or different.
Similar principle, using sound waves, but adapted for blood vessels. Think of it, yeah, like a sophisticated sonar for your neck arteries. The sources talk about the B mode imaging first.
P mode.
Yeah, that gives you the basic grayscale image. You can see the artery wall, see if there's plaque buildup, get a direct look at the structure, and it's real time, which is important.
Yeah.
They mentioned needing to position the probe just right, perpendicular, to get the best view.
Okay, so a live picture of the artery.
But then there's more to it. They add color Doppler. This overlays colors, usually red and blue, onto that gray image.
Right, I think I've seen pictures like that. What do the colors mean?
They show blood flow. Red might be flow toward the probe, blue away, or vice versa. It depends on the setup.
Yeah.
But crucially, the intensity or brightness of the color tells you about the speed of the blood flow.
Ah, so not just direction, but speed, too.
Exactly. And the sources mention something really interesting called color aliasing. This happens right where the narrowing is worst, where the blood speeds up dramatically to get through.
Aliasing, like an artifact.
Sort of. The blood is moving so fast it actually exceeds the speed limit the machine is set to detect accurately for that color scale. So the colors kind of wrap around, look mixed up or incorrect right at that point. It's a strong visual clue for the doctor that there's a spot of very high velocity, indicating a significant stenosis.
Wow, okay. So the machine kind of throws up its hands, but that tells the doctor something important.
Precisely. And then there's another layer with ultrasound, spectral Doppler. This doesn't just show color, it generates a graph, a waveform, showing the exact velocity pattern over time at a very specific point the operator chooses.
A graph of the blood flow.
Yeah. And the sources point out how the shape of this waveform changes drastically after a blockage. Normally it's a sharp peak, but downstream from the stenosis it gets dampened, the upstroke is delayed, the peak is lower, and the whole waveform looks more chaotic, showing turbulence.
So it's measuring the effect of the blockage on the flow downstream.
Exactly. The sources really emphasize how valuable this combination, the B-mode image, the color flow map, and the spectral waveform analysis, is for preoperative assessment. It gives structural and functional information.
That is incredibly detailed for just using sound waves. So beyond ultrasound, what other ways do the sources say doctors get this inside look?
Well, another major technique discussed is magnetic resonance angiography, MRA. And specifically, the sources often highlight contrast-enhanced MRA, or CE-MRA.
MRA, okay. Using magnets, is it better than ultrasound?
It offers different strengths. One source actually cites a meta-analysis showing CE-MRA has really good accuracy for finding severe stenosis. They quote figures like 94% sensitivity and 93% specificity. So very reliable.
That sounds impressive.
Yeah. And they compare it to other MRA types like time of flight or TOF MRA. The sources suggest POF can sometimes overestimate how bad a stenosis is because of certain artifacts, although they do mention newer 3T machines are improving TOF.
Okay.
A key advantage of CE-MRA that the sources point out, especially compared to CT scans of the arteries, is how it handles calcium.
Calcium.
In the
Yeah,
plaque.
exactly. Arterial plaque often has calcium deposits, which can be quite dense. On a CT angiogram, or CTA, this dense calcium can sometimes block the view, making it hard to see how much the artery is actually narrowed underneath or within the calcium.
Ah, I see. The calcium gets in the way on the CT.
Right. But sources say CE-MRA isn't really limited by that arterial wall calcification. It gives a clearer view of the actual channel the blood flows through, even if there's calcium present. They also mention MRA might be an option if ultrasound is unclear, perhaps even in patients with kidney problems, and touch on some advanced techniques like 3D black blood imaging for looking at the artery wall itself.
So MRA, especially the contrast-enhanced type, sounds like another really powerful tool, giving an accurate map that gets around that calcium problem CT might have. Where does that leave CT angiography, the CTA?
CTA definitely gets mentioned in the sources, often, like you said, for comparison purposes with MRA accuracy. It's also noted as being useful in certain situations, like evaluating neck trauma involving the arteries. Okay, so maybe more for emergencies or specific cases.
In the context of evaluating standard carotid stenosis for potential surgery, based on these particular sources, the emphasis seems to lean more towards the combination of ultrasound and MRA, partly due to that advantage MRA has with calcified plaque.
Got it. And what about the older gold standard, angiography, where they inject dye?
You mean digital subtraction angiography or DSA? Yeah, the sources refer to it as the benchmark, the reference standard when they're judging how accurate MRA is, for example.
But they don't use it as much for the initial diagnosis now.
It seems less common for the initial evaluation of carotid stenosis based on these texts, mainly because it's more invasive. It involves inserting the catheter. Ultrasound and MRA are non-invasive or minimally invasive. DSA is still mentioned for other things like looking at kidney arteries, but for the carotids, these sources focus heavily on ultrasound and MRA first.
Okay, that makes sense. So doctors really have this sophisticated toolkit to map out the problem before they even think about surgery. It's not just one look, it's multiple angles, focusing on structure and function.
Absolutely. It underscores the detailed diagnostic workup involved.
All right, so the problem's identified, the map is clear. How do the sources talk about getting the patient ready for the actual procedure, particularly thinking about medications?
Yes, medications. This is definitely a significant point in the sources, and it really highlights a core strategy: trying to prevent clots, especially those tiny little ones, the microemboli, from causing trouble around the time of the surgery.
So it's about making the blood less sticky, essentially.
That's the idea, and the sources get quite specific. One clear recommendation, which references an older but seemingly foundational study from 1999, is about aspirin,
Okay, standard aspirin.
specifically low-dose aspirin. The sources mention a range of 75 to 325 milligrams daily. They emphasize this low-dose range, suggesting it's preferred over higher doses for reducing the risk of another stroke for patients heading for this surgery.
Interesting. Low dose is key. What else?
But beyond just aspirin, there's discussion about potentially adding a second antiplatelet drug, clopidogrel. You might know it by the brand name Plavix.
Right, often used together.
Exactly. And the sources cite specific studies. They mention names like Caress and AmbiDTAP that found combining aspirin and clopidogrel seemed to reduce the number of those microembolica signals. Those are the tiny particles detected, often using transcranial Doppler, heading towards the brain in patients who have symptomatic narrowing.
So the combination therapy is aimed specifically at cutting down those tiny emboli, not just general thinning.
That seems to be a major focus highlighted in these sources, yes. They mention one audit where starting this combination therapy, aspirin plus clopidogrel, before the surgery was linked to fewer patients having another TIA or stroke while waiting for the procedure, and also, again, fewer of those microembolic signals being detected.
That sounds pretty significant, protecting people even before the surgery.
It does. And there's one quite striking detail from a study they discuss. They looked at patients already taking aspirin, and they gave some of them just a single 75 milligram dose of clopidogrel about 12 hours before the surgery.
Just one dose.
Just one dose, 12 hours prior. And compared to patients who got a placebo, that single dose statistically significantly lowered the chances of detecting more than 20 emboli using that transcranial Doppler to monitor within the first 3 hours after the surgery was finished.
Wow. That's incredibly specific. A single dose timed just right, having a measurable effect on particles after the surgery.
Right.
It really shows how focused they are on this tiny clot problem.
It really does. It highlights This isn't just about preventing one big clot during the operation. It's about managing this ongoing risk of small particles breaking loose, both before, during, and immediately after the artery is handled. So this medical prep is crucial.
Okay, so detailed diagnosis leads to targeted medical preparation, all focused on risk reduction. Now let's peek inside the OR based on the sources. What do they reveal about the actual surgical technique? How is it done?
The sources paint a picture of, well, very careful and precise work, as you'd expect. The typical approach starts with an incision in the neck, along the front border of one of the neck muscles. They call it an anterior cervical incision.
Okay, standard neck incision.
Yeah.
Then what?
Then the surgeon has to carefully dissect down through the layers of tissue to get to the carotid artery itself. The sources specifically mention having to mobilize or gently move aside the large vein that runs alongside it, the internal jugular vein.
Getting it out of the way.
Right. And a really critical point emphasized in the texts is using what they term a minimal touch technique when actually handling the diseased artery, the one with the plaque.
Minimal touch. Why is that so important?
Because that atherosclerotic plaque can be fragile. The sources stress that any rough handling, too much poking or pulling, could cause distal embolization.
Pieces breaking off and heading to the brain. There it is again.
Exactly the same risk we talked about with the medications, but now being addressed through careful surgical handling. It's about not knocking loose any debris while exposing and working on the artery.
Makes total sense. What else do they describe?
The surgeon then needs to clearly identify the key landmarks. This includes the carotid bifurcation, that's the fork in the road, where the common carotid artery splits into the internal carotid, going to the brain, and the external carotid supplying the face and scalp. They also identify nearby branches, like the superior thyroid artery and other branches coming off the external carotid.
So mapping out the specific anatomy in that patient?
Precisely.
Yeah.
And navigating involves not just blood vessels, but nerves too. The sources mention the importance of protecting nearby nerves. They specifically bring up the recurrent laryngeal nerve, which is vital for your voice, noting care should be taken, although the main work for CEA is usually a bit higher up than where that nerve is most typically vulnerable.
Still, nerve protection is clearly a priority.
Yeah, fine. They also mention that sometimes to get better exposure, especially a bit lower down, a muscle overlying the artery area, the omohyoid muscle, might need to be divided, and some small nerve branches in that area, part of the ansa cervicalis, might also be cut. The sources suggest this can usually be done without causing significant problems. They do add, though, that the upper part of that ansa nerve network leads towards the hypoglossal nerve,
Which does.
controls tongue movement. So again, it just reinforces this theme of meticulous dissection and identification of all these fine structures in a crowded area.
Listening to that description, you really get a sense of the sheer precision involved. It's not just fixing a pipe. It's incredibly delicate work in a really complex neighborhood, anatomically speaking, trying to clean out the blockage without causing any collateral damage.
That's a very good way to put it. The sources definitely convey that blend of detailed anatomical knowledge and highly refined surgical skill.
Okay, so the surgery itself is done carefully. What happens right after? What do the sources say about the immediate post-procedure period and maybe longer-term things to keep in mind?
Well, right after the surgery, in those first few hours and days, the sources reiterate that risk of sustained embolization. Remember those tiny particles?
Yeah, the microemboli.
If they continue to be released in significant numbers after the artery has been cleaned out, the sources note that's actually a predictor, a warning sign for potentially developing a stroke caused by a clot in the postoperative period.
So the vigilance continues immediately after closing up.
It seems so. It underlines why things like that post-op transcranial Doppler monitoring mentioned in that clopidogrel study can be informative. They're still watching for those particles.
And what about the medications like the aspirin and clopidogrel? Do they continue?
The sources imply they do, yes.
Yeah.
While they spend more time detailing the preoperative medication adjustments, they state that the general principles of antithrombotic therapy using medications to prevent clots for cardiovascular prevention apply just as much after carotid endarterectomy as they would after, say, carotid stenting.
So keeping that blood less sticky remains important long-term.
Absolutely. The surgery fixes the immediate blockage, but the underlying condition that caused the plaque is usually still there. So continued medical management, likely including antiplatelet therapy, is part of the long-term strategy to reduce the risk of future events, according to the sources.
Right. It's a continuous process. Fixing the urgent problem, then managing the chronic one.
That's a good summary of the approach described.
Well, this has been a fascinating deep dive. We've really journeyed through these sources on carotid endarterectomy. We started with the why reducing stroke risk, especially in symptomatic patients. Then we looked at how doctors diagnose it using these really quite sophisticated imaging tools like Duplex ultrasound and MRA to see the blockage and understand the flow. We spent time on the preparation, particularly the medications like low-dose aspirin, sometimes with clopidogrel, and how the sources emphasize their role in preventing those tiny, dangerous microemboli.
Mm-hmm.
Then we got a glimpse into the OR, highlighting that meticulous, minimal-touch surgical technique needed to clear the plaque safely while navigating nerves and vessels. And finally, touching on the post-op period, where the focus remains on preventing clots and emboli leading into long-term management.
And I think what really comes through, even though these sources are quite technical, is the sheer amount of careful planning and layered strategy involved. It's not just one thing. It's accurate diagnosis, proactive risk reduction with medication, precise surgical execution, and continued vigilance afterwards. Seeing all those pieces described in the sources, understanding how they fit together, well, I think that can be quite empowering if you or someone you know is potentially going through this. It shows the depth of thought behind the procedure.
It absolutely does. And it leads to a final thought, really. We've heard so much from these sources about the immense effort and precision focused on managing the risk from these tiny particles, these microemboli, that can cause such big problems like stroke.
So looking ahead, what kind of truly revolutionary technologies or maybe completely different approaches might we see in the future that could tackle this problem even more effectively, making brain-related procedures like carotid endarterectomy even safer? What's the next frontier in protecting the brain during interventions like this?